Welcome to the IC on Making Lid Reconstruction Easy. We encounter various cases of lid trauma in our daily OPD. So lid suturing or reconstruction is a basic skill which all ophthalmologists should acquire. Doing it in a perfect way to increase the functional and aesthetic outcome needs more knowledge about the basic surgical techniques and wound and scar management. So I hope our IC will help you. So first we will be having a talk by Dr. Abarna KS on the principles of lid reconstruction. She has completed her fellowship from Aravind Eye Hospital, Tirunelveli. Now presently she is working as a consultant oculoplastic surgeon at Chaitanya Hospital, Kollam.
Good morning. Lid reconstruction can be linked into solving a jigsaw puzzle because fitting the pieces will give a functional whole. But in order to retain the proper anatomy, we should know some basic principles of lid reconstruction, and we should have a thorough knowledge about the anatomy of the eyelid. So today I'll be discussing the principles of eyelid reconstruction. Various indications for lid reconstruction are lid coloboma, traumatic defects, burns, various tumors requiring resection, like that. The primary objective of this procedure is to restore the physiologic functioning of the eyelid, like maintaining vision, lid closure, mobility, tear drainage. Secondary objective is to restore the anatomic integrity, and final objective is to maintain best possible cosmesis. This can be attained by maintaining the symmetry between both eyes as much as possible. These are some of the cases which are managed by non-ophthalmic doctors from outside casualties. In the first two cases, there is lid margin involvement which is not taken care of, resulted in lag of thalamus and exposure. In the third case, you can see that it is medial to the medial canthus, medial to the punctum, so it is involving the lower canaliculus. But here the canalicular injury is not addressed, so results in lifelong epiphora for the patient. So during the preoperative evaluation, we have to look for certain factors which has role in deciding the choice of the procedure as well as the prognosis of the procedure, like whether it is involving upper lid or lower lid, whether it is a superficial or a deeper one, if it is involving the lid margin or a non-marginal tear, then size of the defect, shape of the defect, location of the defect, then elasticity of the lid, that in turn depends on the age of the patient, then condition of the periocular tissues and intraocular structures, etiology of the defects, and status of the lateral and medial canthus. And then we have to check whether it is involving the anterior lamella, that is skin and orbicularis, then posterior lamella, retractors and tarsus and conjunctiva, or if it is involving the involving both the lamellae, then we have to do a separate suturing for each lamellae. One important concept is relaxed skin tension lines or RSTL. These are basically the orientation of collagen fibrils. So whenever you are making an incision or doing suturing, try to orient it parallel to the RSTL. This will help to minimize the scarring. Another important concept is line of maximum extensibility or LME. It is basically the increase in length of skin under pressure. So whenever a wound is healing, the maximum tension should lie parallel to LME, that is, it should be perpendicular to RSTL. So the wound should be parallel to RSTL so that the wound tension will be parallel to LME. There is one exception in the lower lid. When we are making an incision in the lower lid, we have to make it perpendicular to the RSTL, because if you are making it parallel to the RSTL, it will be parallel to the lid margin. So when the wound is healing, there will be contraction of tissues that may result in lag of thalamus and malposition. So in lower lid, we have to make it perpendicular to the RSTL, and in remaining position, it is parallel to the RSTL. And before starting suturing, we have to thoroughly clean the wound and make sure that we have removed all the foreign bodies, and remove the tissue only if it is devitalized. Try to preserve normal tissues as much as possible and use the smallest caliber sutures possible, and make sure that the wound edges are not overlapping, but it should be in an inverted position. This we can make sure by taking the loop such a way that in the superficial part it should be narrower and the deeper part of the loop should be wider. And if it is a round effect, convert it into an elliptical shape, and there should not be any tension or pulling effect on the suturing. Whenever there is presence of orbital fat, it is an indication for exploration of the levator muscle and aponeurosis, and we may have to repair the levator aponeurosis if it is lacerated. But during suturing, you should make sure that you are not involving the septum, because if we are suturing the septum, there will be vertical shortening of the septum that can result in lid retraction. If it is a smaller defect, we can approximate it, but if it is a larger one, we may have to take flaps or grafts. Flap is basically a tissue with its own blood supply, and graft is a piece of tissue without a blood supply. So in general, if one of the lamellae need to be reconstructed, we have to use a flap, and the other lamellae can be replaced either with a graft or flap. For anterior lamellae, the graft or flap should be matching with the color of the surrounding tissues, and posterior lamellae should be with a tissue which is smooth and capable of producing mucin for lubrication. Donor tissue options for anterior lamella include skin from the postauricular supraclavicular area, medial side of the upper arm, in children from the groin area, then lax upper lid skin that we can use. Posterior lamella options are nasal mucosa, buccal mucosa, palatal graft, conjunctival and tarsal graft. Full thickness defect we can classify into various types like small, medium and large. For young patients, it is small means less than 25%, but older age group it is more than 30% because their skin is more lax. And larger means for young patients it is more than 50%, but older individuals it is more than 60%. And for anterior lamellar defect, if it is smaller, we can allow healing by granulation as in a lysis vere technique. Then we can go for primary closure, mucocutaneous flaps or grafts. Then full thickness defect, based on the size and whether it is upper lid or lower lid, we have different options that will be discussed by the coming speakers. Basically for upper lid, we have to borrow from the forehead or lower lid, and for lower lid, we have to borrow from the cheek or forehead. So my take home message is the lid reconstruction should be a customized approach for each patient, and we have to adhere to the logical principles and follow a stepwise manner, and if needed request assistance from the subspecialist. Thank you.
Thank you, Dr. Aparna, for that comprehensive coverage of the topic. Next, I invite Dr. Jijo Joseph for his talk on tips for a scarless surgery. He has completed DNB in plastic surgery with a national gold medal, hand surgery fellowship from St. Andrews Hospital, UK, currently working at Mitra Hospital, Malabar Medical College, Kozhikode.
Good morning. I'm Dr. Jijo, and I'm going to talk about the tips for scarless suturing. So many of the points that I'm going to discuss here has been already discussed. So we'll just brush through a couple of points. Now, by scarless suturing, we mean the scar minimization techniques, or the techniques by which you can reduce the incidence of a bad scarring. Scarring is definite, but there are certain ways by which you can reduce the occurrence of scarring. So these are the type of suturing that you can use. For me, personally, it doesn't matter what kind of sutures you use. I prefer interrupted simple sutures. You could do subcuticular or absorbable as well. The alternate techniques to suturing include adhesives and tapes. So adhesives are the substances that you apply on an already opposed wound margins to keep it in place so that it heals better. And tapes are the substance that helps to keep the wound margins together. So if you can oppose the wound margins together mechanically, there are different ways of doing it. You can apply the tapes or steri strips on the top so that the wound heals properly. So by using these techniques, you can basically avoid the skin sutures on the top. So many parents will be very worried about the about placing sutures on the skin margins. So these are possibly the techniques that you can use so that you can avoid sutures. Now, I would say these are the more important points when you consider suturing, the intraoperative considerations. So in a trauma setting, you need to freshen the skin margins, and if it's an elective operation, the site of incision placement is important. And additionally, you need to handle the tissues in an atraumatic way, and you have to use the appropriate instruments and adequate sized sutures. Now let's see a bit more on the site of incision placement. Now you have seen that when you place an incision, it has to be along the natural creases. If you look at the forehead, you could see the creases are in a transverse manner. So if you could place the incision along it, the resultant scar will be much less conspicuous. Secondly, when you place an incision, you have to make sure that you does not cross the facial subunits. If you look at these diagrams, you could see so many facial subunits. Now, that also goes with the same principle. When you cross a particular subunit, you are likely to cross the natural skin creases, which could eventually lead to a bad scar. Thirdly, you have to avoid excessive tension during suturing, which could potentially lead to skin margin necrosis and eventually a delayed wound healing and a hypertrophic scarring. So how could you avoid excessive tension during suturing? You could use a local flap or a full thickness skin graft, or you could do adequate undermining so that you could close it without tension. Now, this gentleman came to my OPD with a sutured wound in his lower eyelid, resulting in an ectropion of the lower eyelid. Now, we recreated the defect and covered the defect using a full thickness skin graft from his post-auricular area. Is that it? Is there anything more to the suturing techniques to avoid a bad scar? Yes, I would say the post-operative management is as equal as the intraoperative management of a wound. In this, the most important aspect is a good scar massage. Secondly, you can use a scar gel or scar sheet, which essentially contain the silicone. So the substances that are included in the scar gels or scar sheet essentially block or lock the moisture within the wound, that helps to reduce the inflammation and also help to remodel the collagen so that the scar will be smooth and the extra proliferation of the collagen fibers will be arrested. And that's all for today. Thank you. Yeah, please. Yeah. So I mostly use Hexalac Ultra or Contractubex. There is a smaller, less costly version of it. It's called as Silinoscar Gel. So it's basically a bit less costlier compared to the other brands.
Similarly, for this hypertrophic scars, I mean, do you advise intralesional trichodes, 5-fluorouracil? What about your...
Yeah, the occurrence of this hypertrophic scarring is less predictable. So the first thing that we say post suturing is to do a good scar massage. We start the scar massage in around 10 to 14 days, and we ask them to wait for 1 month.
Okay.
So in a month's time, if you see that the scar is proliferating, we advise them scar gel, and again wait for another 3 months. Most of the scars will resolve. In case if the scar is not resolving with a scar massage or a scar gel, we advise a Kinacort injection. Yeah.
Thank you.
Can you elaborate on scar massage, how it is done,
Yes.
how long?
Yeah. So you need to do a proper scar massage, by which I mean you have to apply good amount of pressure on the scar. So the advice that we give in our institution is scar massage for 5 to 10 minutes twice daily. So some people ask, okay, sir, is it okay that you do once daily or many times a day? So I would say if you could do more frequently, it's better.
After how long? After suture remove? I mean,
Yeah,
when to start?
10 to 14 days.
Okay.
We remove sutures in 5 days. Actually, the scar is the sensations over the scar will be less compared to the normal skin. So we just ask them to do massaging with Vaseline or coconut oil, liquid paraffin, or any moisturizer, as a matter of fact.
Okay, thank you, Dr.
Thank you.
Dijo Joseph.
Thanks.
Next is Dr. Anish Sridhar from Little Flower Hospital, Angamali. She is the senior consultant and she has got vast experience in oculoplasty for many years. Her talk is on lid malposition, repair technique and strategies. Over to you, ma'am.
I am going to deal with the usual entropion, ectropion. So, so first we'll deal with the upper lid entropions. Upper lid entropion is never involutional. There is a vertical shortening of the posterior lamella, the tarsus, conjunctiva, upper lid retractus is usually due to contracture. It's never involution. That is a quiz question. And the treatment depends on the thickness of the tarsal plate. If it's a thick tarsus or is it a thin tarsus? Thick tarsus, you can do a wedge resection or a tarsal fracture rotation. We don't do wedge resections nowadays. Tarsal fracture rotation is the fashion nowadays. Thin tarsus, you can do a lamellar repositioning. This is seen in Steven Johnson or Alkali Burns. So anterior lamellar repositioning, you are splitting the lid into anterior and posterior lamella. The posterior lamella at the gray line. The posterior lamella, the anterior lamella contains all the lashes, and the whole length of the lid, except the lateral ends, lateral and medial ends are split. And this is, you cannot use cautery because the lid is as you're repositioning the lid, it has to take up, so little a bloody surgery. And you can do a blepharoplasty. I am sitting at the head end of the patient, and the video is taken under a microscope. And as you shorten the anterior lamella, there can be a excess skin which can be cut away with a blepharoplasty. That is upper incision that you are seeing. And so the anterior lamella with the lashes are resutured at a higher position, and this is a post-op appearance. You need not put any mucous membrane graft, but I think if you have lashes in the posterior margin also, you can destroy them and put a mucous membrane graft, so that will not rub on the cornea. So you can see there is no lag of thalamus also. Tarsal wedge resection, this is a very old video actually. Here this is that you can use a cautery and shape a wedge with the base anteriorly, and then when you suture it, the lid turns out. That is a basic principle. That is a tarsal wedge resection. So nowadays what we do is we fracture the tarsal plate lengthwise, and you should take care that that incision should be about 4 millimeter at least from the lid margin. You fully incise it so that you can see the orbicularis underneath. That is, you are fracturing the tarsal plate and then putting everting sutures. That's all. These everting sutures are taken out near the lid margin. So when you tighten them, when you tighten the sutures, when you tighten the sutures, the lid becomes everted. You can't fast forward it, I think. So when you tighten the sutures, the lid becomes everted. This is the one, all these entropions and ectropions tend to recur. So this is the one, I think, little bit for some years it stays like that. And cicatricial ectropion, if it is localized, you can do a pentagon excision. And if it is widespread, then you have to release the scar tissue and do a skin graft. Nowadays I don't go posterior auricular, I always take a skin. Even in small children you can take from the other lid. That is a good skin match and it's easy to take also. And what is floppy eyelid syndrome? Where the upper lid is so floppy that the lid opens when the patient lies down. So you have to shorten the lid and tighten the lid. This is done by a pentagon excision. The patient may complain when of lag of patient will not complain of lag of thalamus. Only dry eye, and on waking up the eye will be so dry. So you have to look for this and ask for this. Coming to lower lid entropion, it can be either cicatricial or involutional. So always differentiate between the two before you start surgery. So involutional entropion, the pathophysiology of involutional entropion is always asked as a short note. Here there is vertical laxity of the vertical lid retractors, overriding of the preseptal orbicularis over the pretarsal orbicularis. That is why you see a band underneath the lid. You see in the right eye of this patient. And there is interning of the tarsal plate, and it may or may not be associated with horizontal lid laxity. So how will you differentiate between the two? When you evert the lid returns to normal in involutional, but it returns to the inverted position in cicatricial. So this is a case, you have to look at the horizontal laxity by laterally pulling the punctum and see to which extent the punctum has been displaced. And the snapback test also, you can also measure the excursion of the upper lid, lower lid from the globe. The snapback test in the vertical laxity also has to be measured. So Jones plication is what we usually do. And what all do we correct here? The vertical retractor laxity is corrected by the plication of the retractors, lower lid retractors. The barrier of the suture prevents the overriding of the preseptal over the pretarsal orbicularis. The inversion of the tarsus is prevented by a suture bite through the lower tarsus, and the horizontal lid laxity can be corrected by a lateral tarsal sling or a pentagon excision. So this is a video. So you have to test always if there is a horizontal laxity before starting. The dissection is carried out from the subciliary line under the orbicularis. You can see that the cornea is shining through, it's very thinned out. Now bites are taken from the orbicularis of the lower part of the incision, plicating the lower lid retractors. 2 bites plicating, and then the small bite through the lower edge of the tarsal plate. You can have a gritty feel as you pass through the lower edge of the tarsal plate. 3 such sutures are placed, vicryl, 6 row. And if the end point of the dissection should be a slight eversion of the lower lid. If the lid is everted too much, that means, what does that mean? It means that there is too much of horizontal laxity. So then you have to do a lateral tarsal sling. The skin is then sutured. So this is a post-op appearance. Eye will look a little small in the early post-op period, but it's okay. This can remain as such for a long time. In acute spastic entropion, when the lid is inverted in an acute this thing, you can do lower lid everting sutures. Here the sutures are taken out, taken from the fornix through the conjunctiva and out through the lid margin, near the lid margin, near the lashes. So when you tighten them, the lid becomes everted. But this is a temporary phenomenon. You can keep the vicryl sutures there, but still it doesn't. You have to do a definitive procedure like the Jones later. Now cicatrization of the lower lid entropion. If it's mild, you can just do a levator. The lower lid retractor can be just incised and left as such. But if it is severe, you may have to do a replace that defect that you have created with either a mucous membrane or some graft. So here I have incised the vertical retractors completely, and you can see the orbicularis in the depths of the incision. And now with glue, a mucous membrane which was harvested from the lower lip is placed there. Here too the immediate post-op, the immediate post-op will look good, but after some time it retracts to the original position. Involutional ectropion of the lower lid. So that is just, you have to tighten the lower lid. See this here, the lower lid is not, the tarsal plate is not attached to the lateral orbital margin. So you can do a pentagon excision or a lateral tarsal sling. So nowadays we always do a lateral tarsal sling where the lower lid is split into two layers, and the tarsal plate, both these layers are shortened and sutured separately to the lateral canthus. So cantholysis is being done. You strum and see where the lateral tarsal ligament is, and then cut it fully. Now we are splitting the lid into upper and anterior and posterior lamella. The posterior lamella contains the tarsal plate and the conjunctiva. So now shorten the posterior lamella till where you want it to be tightened. And then de-epithelize the area where you have to bury it. And then pass double-armed 5-0 ethibond sutures. When you are suturing tissues under tension, always put a knot and then suture, otherwise it will cut through. So put a knot there and then pass it to the lateral orbital margin above the lateral orbital tubercle. I have overpassed, it's okay, I'll finish it off. I don't know how much. So, and then shorten the skin also. Okay, so I think this is the last slide. So this is a post-op appearance. This is a congenital ectropion. Thank you.
Thank you so much, ma'am, for that beautiful presentation. We'll take questions at the end of the session. Next, I call upon the chief instructor herself, Dr. Soumya Narayanan. She's a consultant oculoplastic surgeon at Puttala Thai Hospital and Dr. Chandrakant Eye Hospital, and also does a good amount of freelancing. She will be talking about mastering lid reconstruction, basics and beyond.
Good morning all. I will be talking about lid reconstruction basics and beyond under these headings. So first about lid defect not involving the margin. So in this case we can do a direct closure without distorting the lid margin after undermining the superficial tissues to avoid undue wound tension. The tension should be directed horizontally by placing vertically oriented incision lines. If that is not possible, we can go for full thickness skin graft or local skin flaps. So this is a case of direct closure. And if there is a fat in the wound site, that means the septum is breached. So we should explore for the LPS injury. The orbital septum should not be sutured back to avoid eyelid retraction from vertical shortening of the sutured orbital septum. So full thickness skin graft is suitable for simple anterior lamellar defects or in use in combination with vascularized posterior lamellar replacement in case of bilamellar defects. So we can take skin from ipsilateral or contralateral eyelid, as Animam told, retroauricular, inner brachial and supraclavicular areas. These are the ideal donors because of the similar color, thickness and texture. So hypertrophic scar is the most common complication and can be reversed by massage, steroid ointment and silicone gel application. So this is a case of full thickness skin graft of the lower lid. So local flaps are superior to skin graft because of the functional and aesthetic outcome, because they have superior color and texture matching, better blood supply and reduce scarring. So we can use random pattern local flaps which derive their blood supply from perforating mucocutaneous blood vessels, or axial pattern local flaps which derive blood supply from a cutaneous artery. So depending on the reposition method, we can use advancement flap, rotation or transposition flaps. So this is a example of VY advancement flap. This is a case of Mastadi's cheek rotation flap, and this is a transposition flap where we used for a lateral canthal BCC. So axial pattern flaps can be based on superficial temporal artery, supratrochlear artery or angular artery. And lid margin, lid defects involving the margin are very important because we need a precise approximation of the tarsal margin and the tarsus as such, because that gives the integrity to the lid, and any lid margin irregularity will disturb the ocular surface hemostasis. So for that we need to know about these three landmarks, that the meibomian gland orifice posteriorly, gray line in the middle and lash line anteriorly. So when we have a defect, we should do a full vertical height of the tarsus should be excised in parallel incision and should be sutured. So for the lid margin suturing, we can use three sutures, one through the meibomian gland, second through the gray line and through the lash line, either simple sutures or vertical matrix sutures, and the knot should be kept long and incorporated into the skin sutures. So after the suture of the lid margin should be little everted, and then we have to close the tarsus using a partial thickness sutures, and skin and orbicularis has to be corrected. So these are few examples. So if there is again tension during the direct closure, we can do a lateral canthotomy and cantholysis for an additional 3 to 5 millimeters of medial mobilization. So an incision is put from the lateral canthus horizontally to the lateral orbital rim, and cantholysis performed in a piecemeal manner till we get a desired closure. So Tencel's semicircular flap also will help for a direct closure with the medial mobilization of the lid. So for that we have to put for the lower lid we can put a arching incision line marked beginning at the lateral canthus, going upward and coming inferiorly, and skin flap is dissected thoroughly and undermined. A lateral canthotomy has done, and it has displaced nicely for a direct closure. So lateral canthal defects can be corrected using horizontal strips of periosteum or deep temporal fascia attached to the lateral orbital rim and attached to the remaining eyelid margin. A Y-shaped pedicle flap of periosteum can also be used for the lateral canthal posterior lamellae of the upper and lower lid together. So medial canthal defects, we have to attach the tarsal plate to the residual medial canthal tendon or to the periosteum directly, either with a heavy permanent suture, wire or titanium mini plates. And there will be defects involving the lacrimal drainage apparatus that also should be taken care of. So we should suspect a canalicular injury in all cases of medial lid injuries, and probing is diagnostic, and we should suture it as soon as possible, especially within 72 hours. So in this case, we have to first find out the proximal cut-end. For that we can use a fluorescein stained dye and find or air or pigtail probe. So after injecting that, we can see from where it is coming out, and after finding out the proximal cut-end, we can dilate the punctum, pass the monocanalicular stenting through the cut-ends, and later we have to close the pericanalicular tissue using a 80 vicryl, and the lid defect also should be corrected. So these are few examples. Even though the lesion looks the tear look very small, there can be canalicular defects. So this is the mini monoca usually we use for the monocanalicular defects. So the importance of anatomical, functional and aesthetic restoration is very important for the desired outcome. Thank you.
Thank you, Dr. Soumya. So we will come to the last presentation by Dr. Marian Polly, who's the head of orbit and oculoplasty at Giridhar Eye Institute. She'll be talking to us about complex periocular reconstruction.
Good morning. Thank you, Dr. Soumya, for the nice IC. I think this is a complex periocular reconstruction. I'll just show some cases. Basic principles we have all learned from Dr. Soumya regarding the flaps, grafts, etc. So first I'll start with the masquerade procedure. So this is a procedure where it is used when the upper lid and lower lid is deficient. Like most of the time we come across either upper lid or lower lid. But if both the lids are deficient, what can we do? So this is a kind of total tarsography by suturing the mobilized conjunctiva from both fornices and covering the anterior surface with a split graft. But here some problems is usually done in extensive burns, then air blepharon, etc. Thing is, the lid is unstable and can get lag of thalmos. So I will just show the surgical steps. So first, the whatever lid available is split into anterior and posterior lamella. Then the posterior lamella is sutured together. Sometimes you can only conjunctiva, so you can close the conjunctiva together. If there are some residual lashes are there, you can actually excise the lash bearing area. So then create a wide defect like this and cover this with a full thickness skin graft. Initially the procedure when Converse was introduced, he used split thickness skin graft, but it has lot of contraction, and nowadays people are using full thickness skin graft. The skin graft can be taken from the sides which described by Dr. Soumya. And bolster dressing is done for 1 week. So after 2 months, you can divide the central part of the flap, keeping the both the candide intact. And most of the time, we are doing when the cornea is compromised and the regular tarsography will not help. So further flap division can be done at 3 months, retaining the canthus depending on the situation. So this is one patient, he is 46 years, hot water burns, had undergone multiple reconstructions from elsewhere, and in fact he was referred to us for evisceration. So then, when we looked into it, we thought we will do masquerade. So I operated along with Dr. Vinay, our corneal surgeon. So he underwent masquerade procedure with the penetrating keratoplasty. And after flap division, he was doing well, and there is no lag of ophthalmos. Only problem, the blink will be little deficient, but that is why you are keeping this eye lens on both sides. So this is again another young girl. She's had total it's a kind of coloboma involving both upper lid and lower lid. This is a congenital defect, it's a syndromic baby. Somebody has already attempted a tarsography at birth, but somehow it didn't work. So one eye, when the child presented to us, left eye already perforated almost into pre-thesical stage. So right eye, we thought we will save the vision. So again, we did a masquerade procedure and kept it like this. And after 2 months, we did a partial flap division, keeping the central area. And at this point, she was awaiting keratoplasty, and recently she underwent anterior lamellar keratoplasty. And now she is actually able to read at least to 3 meters, and she is awaiting school now. So now coming to the upper lid reconstruction. Upper lid reconstruction when the defect is more than 50%. So this is the defect. You can see almost more than half of almost full lid is not there. Only the good advantage is the canthus is intact. So you need to reconstruct only the lid. So we go for Cutler-Bird procedure. So in Cutler-Bird, what we do is incision is 2 to 3 millimeter down the lower lid margin, and it's a composite flap taken and attached to the individual layers, conjunctiva to conjunctiva, muscle to muscle. And after 4 weeks, the flap is divided and the lid margins are formed, and this is his postoperative picture. And there is no lag of ophthalmos, even though minimal retraction is there. So coming to another case again. So this is a tumor involving the upper lid as well as the canthus. So here you have to reconstruct the canthus also. This is the defect after excision. So here what we have done is, one option is you can go ahead with the Cutler-Bird and you can get away with Cutler-Bird. But actually Cutler-Bird, the thing I feel it is not a physiological because it doesn't have any much stability. So in this case what I did is, I did reverse modified Hughes. We know Hughes is the procedure done for lower eyelid reconstruction. So we have reversed the Hughes. So what we do is, incision is 2 millimeter beneath the lid margin, and lift conjunctiva and tarsus. Tarsoconjunctival is again a tarsoconjunctival flap. Suture it to the residual conjunctiva in the upper lid, and then residual, there's a defect, so that here the tarsus is only 2 millimeters. You need to get little more stability. So I have taken a free tarsal graft from the other eye to increase the length of the lid, because the upper lid, the length of the tarsus is nearly 8 to 10 millimeters. So at least you need some 6 millimeters at least. I mean minimum 4, but 6 millimeter gives you very good result. So now we have got a flap and then a graft. So now what I did is I mobilized the orbicularis from the orbital part and kept it over the top. So this is the mobilized orbicularis over the graft, that is free tarsal graft taken from the other eye, and then I covered the anterior lamella with a full thickness skin graft. So this also he underwent flap division at 4 weeks and he did well. So this is another method of reconstructing the upper eyelid. This is also a similar case again. So nowadays I prefer reverse Hughes. So now the defect is this is another patient where the defect is involving the both lateral part of the upper eyelid, canthus, and lateral part of the lower eyelid. So this is the existing defect. So for this posterior lamella, I have taken a periosteal flap. She had a very loose lid, so periosteal flap from the lateral orbital rim. And for the anterior lamella, I have taken a Fricke, and what I have done is, this flap I have divided into two. I mean, basically one part goes to the lower lid and one part to the upper lid, and the rest of the defect is covered by advancement flap, and there is a small skin graft also. So she also did well with even though aesthetic is not very great, but she's doing well. Because in oncology, we look more into the principles like 4 millimeter margin clearance rather than the aesthetics. So lower lid cuke, I'll just take 1 minute. So this is an extensive lower eyelid defect. Again, sebaceous gland carcinoma. So it's naturally Hughes. This is a small video. So this is the Hughes. The other one is the reverse Hughes. So again, 4 millimeter tumor is removed. So this is the defect. Here also the canthus is involved. So for the canthus, I have taken a periosteal flap. Then for the Hughes flap, tarsoconjunctival flap is taken, and it is attached to the lower conjunctiva. Then the upper lid, I form the canthus. So these are the suturing part. So canthus, periosteal flap, here direct closure, and then posterior lamella by Hughes. Then for the anterior lamella, I have taken a small Trippier flap. So the skin is, she had very much loose skin. And this is rotated down. The good thing is like it has got a bucket handle effect. So it will not go for a lower lid retraction. And sutured to the residual anterior lamella. So this was her postoperative picture, and she did well. The challenges are, there are some real challenges. That is, he is a one-eyed patient with an extensive BCC with black cataract. So here I don't want to do a bridge flap because he will be blind for another 2 to 3 weeks. So what I did is, since the other eye I have taken a free tarsal graft and have taken a skin graft, he had an element of graft necrosis, but anyway he did well, and he underwent cataract surgery also. So this is another defect again involving middle canthus, extensive the whole lower lid. So again, lower lid, posterior lamella with the Hughes, and anterior lamella have taken an nasolabial flap, and the lateral part with a small skin graft, and again BCC, and she also did well. Eyelid avulsion, composite graft if you get the residual eyelid. And for the eyebrow defects, you can actually get away with the myocutaneous flaps, advanced from both sides, suture together, and they will do well. So to conclude, it's a very complex undertaking. Always respect the anatomy. We need to reconstruct both the lamella, and if you are not able to reconstruct, at least do a temporary tarsography and get a help from somebody to reconstruct it. Very gratifying. Thank you.
Thank you, Maria ma'am, for this wonderful presentation. We are open for questions.
Regarding that masquerade technique, will you leave the eye like that for long, or you have to extend it later on? You told about keratoplasty, no?
During keratoplasty, it was released, the tarsography was released, and then resutured it by, because there is no blink for all these people. Blink reflex is not there, so that can lead to all the surface problems. So for them, at least 1 meter vision is more important. So rather than the aesthetic, yeah. So child is now almost post keratoplasty 6 months, and she is doing extremely well. I hope she will do well. Still blink is a problem.
Any questions from the audience?
Dr. Jijo, can I? Dr.
Yes.
After skin graft, will you keep bolsters or just keep sutures?
Yeah. post full thickness skin grafting, it's a standard practice to keep a bolster. We always keep a bolster, but not necessary though. I've seen some plastic surgery consultants not using it, but the majority of the consultants prefer to do so. 5 days. Generally 5 days, and then we leave it open. That's all.
So this is my question to Marian Madam. When you take the free tarsal graft from the other eye, how do you leave the defect as such, or is there anything that you do?
So most of the time you need to get at least 3 millimeter height. So even if you take 3 millimeter, 8 minus 3 is 5. So I mean, never seen any entropion so far in the last 10 years. But it's a very good graft, free tarsal graft. Only thing you have to tell the patient, and like, the other eye will be closed, and this eye again you cannot close it immediate post-op. You can close it for at least 1 hour so that no oozing, nothing. But so far, no, nothing, no problem. No, I'll just keep it open. No, I will just keep it open for healing by granulation. Yeah. It is like, little tricky, but I don't take more than 3 millimeters. Maximum is only 3 millimeter height.
So I had a question to the speakers and the panelists. So there was this case of a 17-year-old boy who was taking treatment for ALL, and he's on maintenance chemotherapy. So he had come with an acute lid abscess. So eventually he was admitted, and then he took IV antibiotics. But what happened was, in the period that his wound was healing, there was almost complete necrosis, and the posterior part of the upper lid just fell off, including the tarsus and the lash margin. Luckily for now, his cornea is not exposed, but the remaining of his lashes are causing him a trichiasis. So when would you choose to do, and what would you choose to do in this patient? But there is almost 3/4 of the tarsus is gone, madam. Only medially there's a small part of tarsus that's remaining.
And where are the lashes then?
The tarsus is remaining only in the medial part, but the almost mid part of the lashes are intact. The lateral half, the tarsus has fallen. Skin, the anterior lamella is intact.
Oh, skin is intact.
Skin is intact.
The abscess has come in. You can still give everting sutures, no?
But the support
can't get
is
the
lacking
picture
because
actually.
of,
Okay.
it is.
There are no lashes. Yeah.
Cases with the primary immune deficiency and very bad abscess, getting the whole lid is getting sloughed off, whatever residual lid is creating all the troubles like trichiasis. So what I did is, like, once the general part is stable, like the baby is systemically stable, just take away the lashes, like eyelash resection.
You can give us scleral contact lens.
But pediatric,
For Steven Johnson and all, now it's very effective. Cornea people give scleral contact lens, because sometimes the lashes will grow inside, and electrolysis and all doesn't work.
eyelash resection, electrolysis will not work. You can take away 2 millimeter of the lash bearing area and let it heal by granulation.
It is multiple and all.
But it works, yeah. It's only 17 minutes. I think later cosmesis can be a problem. Anyway, cosmesis is going to be a problem.
He's more concerned about the part where he keeps getting irritation to the eye.
Yeah. Cornea people can give scleral contact.
Scleral contact.
Similarly, I have a 6-month-old baby with dystichiasis. So in the upper lid, the patient is having lashes, and including in the lid margin, even in the upper palpebral conjunctiva. So we are doing epilation as of now. So what can we do? Is it cauterization is palpebral conjunctivitis. It is causing corneal irritation and even pannus. So anyone has
extensive lashes. We have to spend half an hour taking out all. We are doing it every month.
somebody does. What can we do? 6 months I do.
6 syndromic. Syndromic.
Syndrome, nothing else is there. The cornea is totally opaque. I think for him also, Anita was saying he'll give us clear contact lens. Till after that, what to do? We need 1.5 years and all. I think
The lashes are on the palpable conjunctiva also. When we do electrolysis, it will definitely affect the conjunctiva, and that will also cause more scarring and entropion.
but that is not a definitive procedure also. You have to do something else.
Probably a wedge excision later, and then
If it's
with a
localized, okay.
MMG.
Extensive.
How much of palatal graft do you take for posterior support?
Hard palate, I'm not very. Most of the time, we'll get away with auricular cartilage is there, then other eye tarsus is there. So, hard palate only for cicatricial entropion, otherwise, for tumor reconstructions, never used.
How about
Hard
Dr.
palate,
Jijo?
I've seen a plastic surgeon post plastic surgeon, and it was rubbing on the cornea. It's not enough if you just keep it there.
If
It
Jijo,
will erode through the conjunctiva and it will rub on the cornea.
if you could run us through, do you use a lot of palatal mucus graft now?
We hardly use palatal grafts. Basic thing is that for eyelid reconstructions, I just send it to her. So whatever she asks for, I'll just go for it. That's all. So the first choice would be buccal mucosa or then palatal, that kind of stuff.
So thank you everyone for this, for coming to our IC. We will be concluding now. Thank you.